And as a physician, I feel that it is a joint decision. It's a decision between the patient and the physician, in the sense that you want to empower the patient to make the right decision for themselves. So when the question of statin comes up, and let's pick up secondary prevention, and let's define secondary prevention. Secondary prevention is in somebody who's already got a stent or has had bypass surgery or has had a myocardial infarction. So in this group of patients, the best clinical trial is the 4S trial, the Scandinavian simvastatin trial, and it was completed in 1994. It was done under the auspices of Merck, so there is some conflict of interest because they sponsored the trial, they collected the data, they had their own biostatisticians. And when you look at the trial and you dissect it down, you find that the degree of benefit, and I think when you talk about degree of benefit, you should talk about mortality reduction from cardiac causes. And to break it into simple layman's terms, if you treated 100 people with a statin in this group, you will save 0.6 lives per year. So what that means is that 99.4 did not benefit. A little more than 0.5% benefited in terms of mortality reduction. In my mind, that is a very small improvement. And that small improvement comes at the cost of an increased risk of myopathy, worsening of your diabetes, perhaps some cognitive decline, perhaps erectile dysfunction. And if you look at subgroup analysis in this population that's been done by David Diamond, and he's been a stellar person who's helped the low-carb community as well, you find that that benefit is restricted to the group of people who are severely insulin resistant. And insulin resistance can be looked at from a lipoprotein profile standpoint as well. If you see people with high triglycerides and low HDL, these are insulin resistant people. And that's the only group that seemed to have benefited in that clinical trial. So when I am giving a drug to a patient who may take it for a couple of decades, in some cases up to 5 decades, I want to tell them the degree of benefit in terms of absolute risk reduction, not relative risk reduction, which is an exaggerated form of benefit, and empower the patient to decide whether he wants to pursue that or pursue a non-prescriptive option like nutrition, fasting, and exercise. So I would say many of my patients will then come to decide that, hey, maybe the degree of benefit is not what I initially thought, and maybe for my particular situation, this is not worth it. But I can say that in the last 10 years, I have not seen any person from my practice end up having a cardiac event because of the lifestyle they chose. Like, in other words, they go on a fasting diet, they go on a diet that is devoid of refined carbs and sugar. They get into a physical exercise regimen. And I have not seen an adverse cardiac event as a result of that. I'm in a little protected space because all these people have done work for me ahead of time. And so when I go ahead and give my evaluation and come to a empowered decision with my patients, I would say that I'm in a little safer space compared to my colleagues. Now, over time, over the last 10 years, what has happened is that I have been referred either because of my YouTube channels or because of the talk that I gave at Low Carb Denver, which really was a coming out talk for me. Jeff invited me, and that talk has been viewed more than 1 million times on YouTube. So it makes me a little bit infamous. The patient population that is graduating to come towards seeing me are a group of people who are already motivated to do fasting, already motivated to cut out refined carbs and sugar, already motivated to exercise. So it makes my job easier. So I think that people who come to follow me are doing better metabolically in terms of cardiac events and in terms of their overall health, because it's a self-selected population that is now beginning to follow me a lot more than people who are sort of wanting to follow mainstream medicine advice, if that makes any sense. In the beginning, when I used to do it, I got reported to the medical staff that I'm doing something illegal. People wrote that this is the patient of this physician who's presented with a cardiac event to the hospital without a statin. And I wrote back saying that, yeah, but that was one patient. And there are these 10 patients of yours who have come to the hospital with a cardiac event on statins. Cardiac disease is multifactorial. There are so many variables that lead to heart disease, not just lipid profile, but stress, sleep, insulin resistance, inflammation. These are major factors. And I even keep telling them that tomorrow, if I end up having a cardiac event, you should not automatically assume that this is a low-carb cardiologist who is a practicing low-carb cardiologist himself, whose LDL levels range in the high 250s, whose triglyceride levels are low, whose HDL level is high, and his cardiac event was as a result of high LDL. As a physician, I'm exposed to volume stress. I have to see a large number of patients. I'm exposed to stress from taking care of patients in the cardiac cath lab, coming in with cardiac events, myocardial infarctions, dealing with life and death situations. My sleep can be compromised. So there are so many factors that can lead an individual to end up having heart disease. So one should be cautious and not extrapolating too much into one particular variable and say that's what is causing heart disease. I think, in my mind, is that the grassroots movements in terms of evaluating one's own health through metabolic parameters, through getting knowledge from conferences like Low Carb Denver, from gathering some of this information, has leveled the playing field between physicians and consumers of medicine. And so I think it's the grassroots movement that's going to change our paradigm in terms of what is important for our cardiac health, and it's going to protect people like me. And that grassroots movements would be focused on insulin resistance, would be focused on inflammation, would be focused on lipoprotein quality, and not necessarily what your LDL level is. Because just in my mind right now, I can recall 100 patients that I have who have an LDL level above 250, who have maintained a calcium score of 0 over the last 3 years. I can look at many people who have a high LDL level in their 250s, untreated, who have not had a cardiac event in the last decade. So there are so many variables that we don't understand, but we are in a much better place now than we were even 10 years ago. And I think that this paradigm is going to get more refined and better as more and more research happens in this field. So PCSK9 is a protein that the liver makes. And among one of its roles is to go and bind to an LDL receptor. Now we're getting a little geeky, but it's pretty straightforward. The liver has LDL receptors that are sucking up the LDL, the so-called bad cholesterol. And I call LDL the other good cholesterol. But basically, the PCSK9 comes in and binds to the receptor that is sucking up the LDL from circulation in the liver, and it destroys the receptor. So once it destroys the receptor, the LDL remains in circulation and the LDL is higher. And LDL being high does not go with a paradigm that high LDL causes heart disease and hence you need to reduce the LDL. And that's the advent of the PCSK9 inhibitors, because what PCSK9 inhibitors do is that they remove PCSK9 from circulation. The LDL receptor gets overexpressed. The LDL cholesterol is removed from circulation and everybody's happy thinking that they have done something very good. But let's examine this a little further. There are animal studies done in which you do exactly what the PCSK9 inhibitors do. And if you look at this group of animals, they are at higher risk of becoming diabetic. They are at higher risk of getting visceral obesity. That means the kind of obesity in which there is fat in your liver, there is fat in your pancreas, basically abdominal obesity. And you have even higher fat depositions in your heart. They are at higher risk of getting visceral obesity. That means the kind of obesity in which there is fat in your liver, there is fat in your pancreas, basically abdominal obesity. And you have even higher fat depositions in your heart. So you would say, why is that the case? But what PCSK9 does is that it removes the receptor from the liver and from the pancreas that is sucking up a lipoprotein molecule from the circulation that is not just cholesterol filled, but fat filled. So if you have no PCSK9, then these receptors get overexpressed. The fat is removed from the circulation into your liver, into your pancreas, giving you a fatty pancreas and a fatty liver. The second piece of evidence is people who are born with a genetic PCSK9 deficiency. So these are people as if they're taking a PCSK9 inhibitor. So if you look at those group of individuals, they have a higher risks of being a diabetic. They are on an average higher weight than a normal population, and they have higher incidence of visceral obesity for all the reasons that I pointed out to you. And when you look at PCSK9 trials, the Fourier trial, or even the Odyssey trial, but let's take Fourier. They recruited some 28,000 patients. 28,000 patients is a lot. They gave a PCSK9 inhibitor called Repatha, and they dropped the LDL levels to 30 milligrams per deciliter. Now, 30 milligrams per deciliter for people who know about LDL is very low. It's almost close to zero. The control group had about between 90 and 100. And mind you, there are 14,000 patients in this group and 14,000 patients in this group. And if you take that larger number and you show absolutely no mortality reduction, in fact, a little higher mortality in this group, a little lower mortality in this group, that would be considered as an abject failure. So I have pointed out that there are animal studies with PCSK9 inhibitors that show that you are at higher risk of diabetes, you are at higher risk of visceral obesity. There are human genetic trials in populations that show the same thing. And then you try PCSK9 in a human population, and you show no mortality reduction in 28,000 patients. And when you do that, you got to admit that it is abject failure. You should not spin the data and say this drug is beneficial. But primary prevention is important. And we should look at it because the data for primary prevention is even more tenuous. And if you collect all the data, you come across certain very important points. Number one point is that primary prevention does not seem to help women in terms of mortality reduction whatsoever. So there is no clinical trial that shows mortality reduction in women for primary prevention. So let's define primary prevention. Primary prevention means somebody who's not had a cardiac event, like no heart attacks, no stents, no bypass surgery. Now, people ask me, well, I do have some plaque buildup because I have a calcium score that is a certain amount, so that indicates that I have plaque buildup. That person, if they have not had a cardiac event, would still fall in the category of primary prevention. But let's make it a little simpler for some people, and let's take the data that you have zero calcium score. If you have zero calcium score, there are studies that point out that even up to about a decade with statins and zero calcium score, you get no benefit. So if you have a zero calcium score in the right clinical setting, they don't need a statin. Now, if you fall outside this category, you are a middle-aged male and you're taking statins for primary prevention, in that group of people, if you treated 100 people with statins for 1 year, in terms of mortality reduction, it will be 1/10 of 1%. 1/10 of 1%. That means 99.9 would not benefit for that 1 year, 0.1 would benefit. Of course, that's not how it is presented to the physicians who are prescribing these drugs, because they are looking at what is called relative risk reduction. And I love Malcolm Kendrick, and I love the way he describes relative risk reduction. The chances of winning the Texas Lotto is 1 in 15 million. And I come and say, I'm going to increase your chances of winning by 100%. And my patients would think, for sure, I'm going to win it. But all I'm doing is I'm increasing your chances of winning from 1 in 15 million to 2 in 15 million, because the difference between 1 and 2 is 100%. So that's why in primary prevention trials, the quoted number is 20%, 30%, depending on the trial. But when you look at absolute risk reduction, it's about 0.1% for mortality reduction in 100 people treated who are middle-aged men. So on the basis of that, you're going to give a drug to somebody for about 30 to 50 years. Is that something that you want to make a decision as a physician on your own? Do you want to empower the patient to make the right decision? Do you want to discuss with the patient about the potential side effects? I think that's where our medical profession is lacking in terms of critical thinking for themselves. I think we rely too much on key opinion leaders, on societies to make decisions for us.